The following video is the senior author's preferred technique for an all-arthroscopic bone grafting and primary fixation of a medial femoral condyle osteochondritis dissecans lesion. The authors have the following disclosures. The patient is an 18-year-old male who presented to clinic with chronic right knee pain following a football injury 6 years prior in 8th grade. His symptoms and pain increased over the years, including pain with weight-bearing and mechanical clicking and catching of his knee. On physical exam, he is noted to have a 1+ effusion with tenderness of the medial femoral condyle. On imaging, his x-rays and MRI demonstrate a large 30x15 unstable osteochondritis dissecans lesion involved in the medial femoral condyle. The patient was indicated for surgery after discussion of all the risks, benefits, and alternatives of surgical intervention. A standard diagnostic arthroscopy was performed to rule out any other concomitant injuries. The OCD lesion was thoroughly evaluated and probed for size, depth, and stability. The OCD lesion and the underlying bony bed were thoroughly debrided with an oscillating shaver. Following debridement, a power pick instrument is used to drill multiple holes in the base of the lesion to allow for a bleeding surface. The underlying bony bed is then bone grafted utilizing a Yankauer suction tip that has been cut in half. The suction tip is placed down to the bony bed and cancellous bone chips are impacted into the lesion underneath the cartilage flap with the arthroscopic water off to prevent displacement of the bone chips. The OCD flap is then reduced and stabilized into position with two 2.0 mm Kirschner wires perpendicular to the articular surface. A clear cannulated drill guide is then placed over the superior wire and over-drilled and tapped to the proper size and depth. The superior wire is then removed and a bioabsorbable headless compression screw is placed into the hole. The steps are then repeated to the lower fixation point. The now fixed OCD lesion is then probed and the position and stability are confirmed. The knee is taken through a gentle range of motion again to confirm stability of the fixation. The joint is then thoroughly irrigated and the wounds are closed in a standard fashion. Dressings are placed along with a hinged knee brace locked in extension. Post-operatively, the patient will be toe-touch weight-bearing for 4 weeks. The range of motion will be limited from 0 to 30 degrees for the first 2 weeks, followed by range of motion as tolerated thereafter.